Welcome to this episode of Stanford Medicine X Live for Tuesday, June 3rd, 2014. This program is a weekly live recorded broadcast and tweet chat from the organizers of Stanford Medicine X, a conference that explores the intersection of emerging technology and medicine. The views and opinions expressed on this broadcast are those of the individual participants and not necessarily those of the Stanford University School of Medicine or the conference organizers. If you are joining us for the first time, a quick reminder that there's a simultaneous conversation happening on Twitter right now using the hashtag MedX. We will be taking questions from social media this evening, so please make sure to start up your Twitter client to join in the online conversation and interact with today's speakers. Please also make sure to like our YouTube page at www.youtube.com/Stanford Medicine X. We also wish to remind you that registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology in medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. You'll want to take advantage of these programs while our regular registration pricing is still available until August 1st, 2014. Please note you are watching a live online program and there's a delay between real-time events and the live stream you are watching. Tweets from our in-studio guests will appear before you see the real-time events they are tweeting about unfold on the video live stream. The topic of today's program for June 3rd, 2014 is Medicine X, the Student Perspective. Joining us today is a diverse group of students from across the country who have unique perspectives on medical education, patient engagement, and healthcare innovation. The goal of this program is to hear from them, have them share their views with us on these issues, and of course, to answer your questions out there from our viewing audience on Twitter.
Hi everyone, and welcome to Medicine X Live tonight for this June 3rd, 2014. My name is Britt Johnson. You can find me on Twitter on the tweet chat at HurtBlogger, not to be confused with some other handles there. So tonight we have a really good group joining us, and I'll introduce them in just a second. So just to give you a little bit about my background, I'm on the Medicine X ePatient Advisory Board, and I have the pleasure with working with a lot of other wonderful ePatient advocates. And we get to help actually influence some of the conversations that are in healthcare currently. So I'm a patient myself. I've been living with 2 forms of arthritis since I was 7 years old, so for the last 22 years. I'll let you do the math there. And I also deal with chronic complex migraines, so a lot of chronic pain as well as dealing with invisible diseases. So today we have a really diverse group of patients joining us for our discussion. We have Raul Riki. His experience and expertise spans the nexus of medicine, health policy, and biomedical innovation, most recently through his roles as advisor to the UK Chief Medical Officer and Special Assistant to the Maryland Secretary of Health. His work has led to co-authorship on journal articles and book chapters, medical device patents, and editorial writings that have been featured in a growing list of publications, including The Guardian, The Los Angeles Times, Health Affairs, and The Salon. A Goldwater Scholar, Truman Scholar, and World Economic Forum Global Shaper, Raul is currently a Marshall Scholar at Oxford University and the London School of Economics. So thank you for joining us from afar. We also have Hillary Ginsburg with us this evening. She is studying nursing at the MGH Institute in Boston. She is a researcher at the Center for Innovations at Massachusetts General Hospital, where she investigates social media use by healthcare leaders. Hillary is a healthcare hackathon enthusiast thanks to her background as a product designer and her ongoing interest in the patient experience. Tonight we also have Neil Ulrich. He is an engineering student at Stanford University and Medicine X student leader this year. He's interested in the intersections of anthropology, design, and engineering. His current project is focused on using architecture as a provider of well-being, calm, and efficiency in children's hospitals. We also have Anna Clemenson, who we'll see how long she can join us with her busy schedule. She is currently a nursing student at Duke University, and she's worked in the AIM lab at Stanford for the last 3 years. We also have Nicholas Vu. who likes to classify himself as an amateur pharmacy futurist, technology lover, and student working towards his PharmD at the University of California, San Diego. He makes a mean bowl of Vietnamese pho and occasionally hits the surfs in San Diego. I'm going to be down there tomorrow. I'm going to hit you up on that. So, we also have Howard Geode, is a 7th-year student in the MD-PhD program in anthropology at Emory University. His research uses ethnography to understand how dramatic cultural shifts are created in hospital units between doctors and nurses. So we've got a little bit of everyone here tonight, which is really exciting. So I just want to start off. We're going to go across the board, and I just want to ask first, what got each of you interested in healthcare? So Anna, I want to go ahead and start out with you.
Sorry, I had to unmute myself there. I had kind of an interesting road to healthcare. I got out of college, I majored in biology, and I wasn't quite sure what I wanted to do. And long story short, I got my first taste when I began working in an allergy clinic. And I got to give kind of intake patients and see what it was like to be in kind of that private setting. And then, as Britt said, I moved over and I started working with Dr. Chu in the AIM lab, as well as his clinical research side. And that's kind of where I got introduced to not only kind of interacting with patients on that research end, but also kind of taking a look to see at all the different things that you can do within healthcare. So things like education and informatics and things like Medicine X. And so that kind of opened up everything. And from there, I actually kind of found nursing, because I found what I really enjoyed was being at the bedside and taking care of people. So that's kind of how I ended up where I am now. And I find that I'm really loving it. So that's kind of a brief story of how I got where I came to be.
Awesome. So I'll jump to our other nursing student. So Hillary, you mind telling us how you got interested in being a part of healthcare? There you go.
For a good long, I knew I wanted to be in medicine, but I didn't know in what capacity, be it a physician or another kind of clinician. But nursing definitely became my focus and my interest, something that I was going to pursue, just because of the way it can return functionality to a person's life, allowing them to, live with whatever ailment or conditions they have that actually kind of help them return to their life. So I studied chemistry in college and thought for a good long time I wanted to go to medical school, and then realized not at all. I wanted something with more hands-on, direct patient care, and so nursing really fit the bill. And I've had a number of experiences shadowing or working alongside doctors and in other settings, and just seeing the wonderful care that an individual can kind of provide to another person is the great thing about medicine to me.
Well, I can tell you that the nurses, in my experience, are kind of what make or break the day, when you're in the hospital, since, that's who we see in ongoing day. So it makes a huge difference, definitely. So next we're going to jump over to Howard. Would you mind telling us why you got interested in healthcare and kind of where you got to where you are today?
Yeah, so my story is probably a little bit different. I actually fell in love with anthropology first. Healthcare through an anthropological angle is such an interesting, crazy, universal human place to be. So, and hospitals in and of themselves are one of the most complex human artifacts that we have. So I fell in love with anthropology and thinking about how healing happens and how people communicate through healing. And then what I discovered as I pursued anthropology was I didn't want to just be like the anthropologist in the corner. I actually wanted to be able to do something to create change and to work with patients and to work with staff. So I ended up in an MD PhD program because I wanted to be able to combine both sides so that I can sort of study exactly how healthcare works anthropologically, and then at the same time actually have my hands dirty in terms of helping people get better. So.
That's awesome. That's a really neat kind of trajectory that you took there. So glad to have you. And then I think Nicholas is next up on my list. So Nicholas, you mind telling us a little bit about how you got into healthcare?
Yeah, that's a great question. It all started when I was 17. I just graduated high school, and my grandma offered me a job as a pharmacy technician at Health Partners. And I really enjoyed the ambulatory care experience. I really enjoyed being around drugs. I just walked in there and was like, holy buckets, this is really cool. Seeing all the different names, and then looking, and then typing them up, typing up the instructions, and interacting with the physicians, the nurses, and the other pharmacy staff was just really inspiring. So 5 years later, I decided to apply to pharmacy school just to develop those interests. And after that, I took pharmacy informatics my first year in pharmacy school and fell in love with technology and the application of it in the healthcare setting. And the rest of it was just kind of it's all uphill from there.
Sounds good. Okay, and then Neil, we've got you in here. So would you mind telling us a little bit about what got you interested in working within healthcare?
Yeah, so I think at first I wanted to be a doctor, and I came into my undergraduate wanting to do biology, and very quickly I realized that chemistry was not for me, and the pre-med route was not going to be very fun. And I've always loved design and building things, so I started to look at how I could combine my interest in like healing people with design and engineering. So I've been working with the architecture department at Stanford on a couple projects looking at like restorative architecture and how we can kind of apply like medical thinking to traditionally non-medical areas like architecture and product design. And I'm still kind of exploring, but I'm really excited for what the future holds.
Oh, that's great. I'm really excited about the group we have here because it's kind of covering a little bit of everything. So last but not least, Raul, you mind telling us a little bit about what got you started in healthcare and working with it?
Sure, Britt. So, I grew up with an engineering mind through and through. My dad was an engineer, and I whistled away Saturday afternoons playing with Lego kits and looking under the hood of the car and trying to figure out how to make repairs with my dad on weekends. And I always had this mentality of tinkering with devices, tinkering with technology. And it through when I got to college, I was entirely set on studying engineering and formalizing this toolkit that I'd built up over the years. But it became very patent to me that the satisfaction I sort of derived from the tinkering was only linked or primarily linked to the human impact at the end of the day. And I think there was no sort of bigger or more profound impact for me than in healthcare, and that sort of drew me to biomedical engineering in the first instance. Because only as I got older I began to realize that technology wasn't the whole side of the equation, right? I mean, you really had to understand where the patient was coming from, human factors, culture, design, economics, policy. These were all a sort of constellation of factors that really made a difference as to whether technology was effective or not in a healthcare setting. But that was the journey.
Wonderful. You guys are all speaking my language here, so it's really nice to see, I guess, such forward thinking and, in the younger generation here. Gives me hope, that my care will be that much better in another, 10, 15 years, certainly. So I want to move kind of to some of the more big picture ideas. So I think one thing to explain here, just, to some of our viewing audience too, is what is your idea of patient-centered care? So Howard, I want to go to you first as our anthropologist here. So what does that term patient-centered care mean to you?
So patient-centered care has been really interesting because it's been such a new phenomenon. And if you think about it, it doesn't exactly make perfect sense. I mean, in the past, it's always been about the patients in the center. So I think in some ways it's interesting because it's very much a response to what healthcare has become as opposed to necessarily what healthcare should be. I think in the past few years, there's been a lot more pressures on the people working within healthcare to be focusing on documentation or to be focusing on finances and to be focusing on these sort of peripheral aspects of healthcare. So what I see the patient-centered movement is sort of emerging out of that as saying, hey, what exactly are we doing in medicine? What exactly should be the focus? So it's been this sort of strange shift back towards putting this patient in the center and designing processes around having the patient in the center. What I think is sort of interesting is the perspectives among healthcare workers isn't always positive. There's this sort of intrinsic tension between the patient in the center and what we're supposed to be doing as doctors and nurses and all of the other healthcare providers. And I think that's sort of being played out right now as we're sort of struggling with, like how paternalistic can we be? How much patient-centeredness should we actually have? And that's sort of like an active side of conflict right now.
Yeah, absolutely. I mean, it's wonderful to hear you say that. I mean, I think that's a conversation that a lot of the patients have been having very recently, even on Twitter, saying, how did we get to this point? How did we get to the point where we're actually having to come up with the term patient-centered care and remember who the end user is and who healthcare is focused around? It's really interesting that we got so far away from that we're having to come back to it, that it's actually a movement within it, almost as rebellion in a sense. So it's really fascinating to me as well. And Anna, since we have you only for a little bit of time, I want to jump in here and ask you, what does patient-centered care mean more so in nursing to you?
Well, I was thinking about when Howard was talking, and the first thing that came to mind is sometimes I think it's really easy to talk about patient-centered care and kind of really big picture ideas, but what immediately came to mind is how sometimes it's really just the little things that make a big difference. For example, going to your patient, when they had meds due and saying, is now a good time, or would you like to do it later? And so kind of even in those like small instances, still having them be active participants in their care and allowing them to kind of share in that control, because often in the hospital setting it can be very scary when you kind of lose that autonomy and you have people coming in all the time and I think in nursing what we talk a lot about in school is how can you make even those little differences count to people, and to really include the patient in what's going on, explain to them what's happening, and in that way we can really provide that patient-centered care.
Yeah, absolutely. I was just having a conversation last week saying that sometimes it's the smallest things, especially in an emergent setting in the ER when everything's so bad. I've had nurses who will just say, "Oh, I like your nail polish," and as mundane as that seems and as insignificant as it is, it suddenly makes a connection between the two of us, something different that we're talking about, and it's not just a stress level. It reminds her that I'm human. It reminds me that she's human to have recognized this as well, and it allows us, I think, better to communicate by taking those, 5 seconds, a few words, just to say something along those lines or make some kind of joke. And I think oftentimes it's lost how important those small humanistic connections can be to the patient community. So I want to pose the same question also to Nicholas, since you're in a little bit different area. So where do you see patient-centered care working in your field more so? We got you there. You're frozen. We might have lost him. So, Neil, how about I jump to you and ask you, what do you see the term patient-centered care meaning and moving forward?
Yeah, for me, as someone coming from outside of medicine, I can't be an expert in every disease and every patient experience. So to me, patient-centered care really means talking to the patients and using them as experts, and having their knowledge inform my designs. It saves the engineers and designers a lot of work, and I think leads to much better results, because the patients are getting exactly what they need.
Absolutely, and I think that's just kind of the big thing, is keeping the end user in mind, which is so important in design, and just always bringing it back, I think, is the real deal. So I think we'll move on to a little bit bigger question here. So I'm going to pose this one to you, Raul. How have you been exposed to patients in your schooling, and kind of what was your first exposure? What were those experiences like, and was it what you expected?
Yeah, I mean, I think we all have, sort of by virtue of vagaries of daily life, been exposed to patients insofar as our family members having to go through needing some kind of medical care, or classmates or colleagues or friends. But I think my first formal interaction in a patient setting was in high school, actually. I had spent summers volunteering at a local hospital. And I think the big learning experience for me, and this certainly resonates with some of the answers from the previous question, which was that, the diversity of experiences, perspectives, and cultures that each patient brings to a clinical interaction, that each patient brings to a physician, is so important to the process of delivering care. Care, even now, care is already individualized on a patient-by-patient basis, simply because you can't expect the same treatment to work for every patient. Each one is just coming from an entirely different world of experience. So that was a big learning opportunity for me.
And I'll go ahead and let you jump in there, Nicholas, and try to answer that. So how do we get so far away from patient-centered care? Any ideas there? So do you want to try to jump at that one, or I think we've got you back there. Nicholas, can you hear us all right?
Okay, how did we get so far away from patient-centered care? That's a great question, Britt, and I'm glad whoever sent that to Twitter sent it through. So I think there's been, in the past, there's been this very, this model of where the patient often comes into the room of the caregiver, via the physician, a physician's assistant, a prescribing pharmacist, or a prescribing nurse, and the patient pretty much just throws their trust into the caregiver. Everything that comes out of the caregiver's mouth is like the word of God, and then nothing is expected of the patient. But things are totally changing. That model is being flipped over. And the patient is now pretty much becoming more a caregiver now than they ever have in the past. I think the reason that we got so far away from the patient-centered model was because patients it was just expected that they didn't really have to know anything coming into the room. But now that that's changing, and for the better, I think yeah, it's going to get a lot better now.
Definitely. So that question came to us from Alan Brewington, who's one of our ePatient scholars. He's helping us out on the tweet stream tonight, so appreciate that very much. If you have any questions, you can tweet him. You can find him via the hashtag for MEDX, so hashtag MEDX. And if you have any questions for the panelists, please just shoot them that way. So Howard, I'm going to come to you for a little bit about the historical perspective on how we've possibly got so far away from patient-centered care. So.
Yeah, that's actually one thing that I was kind of surprised to be learning, like, as a student. And what really struck out to me is when you talk to older doctors or older nurses and you ask the question, what did care used to look like 10, 20, 30 years ago? They'll talk about how it looked dramatically different back then. And when you actually read about the history of most hospitals, how hospitals look right now is actually a really recent phenomenon. Back in the day, hospitals were places where people would primarily go to die. Our technology to actually do interventional work is very, very recent. That just came back within the last 50, 60, 100 years in hospitals' histories. So we have a lot of these processes that were really built for a different time. So back in the day when nurses had more time to sit down and actually talk to your patients, when doctors carried fewer patient workloads, when days just weren't as busy, when the patient-staff ratios weren't nearly as high as they are now. So what we're seeing is actually a really recent shift, but the fact is that our systems are designed for an older model of medicine and not what we're seeing right now through increased acuity of people getting sick, with more technology in terms of being able to do anything, which means that healthcare has become a lot more complex. So all of these factors are sort of playing in, that sort of driving people's time and energy away from the sort of old models of actually paying attention to the little sorts of things that Anna was talking about as what you would like to do as a nurse. A lot of nurses will talk about now, we just don't have time to do that anymore. It's nursing and doctoring is no longer what it used to be.
So yeah, you bring up a really good point, is that, and I think the driving force behind this switch, I would say, is money, is a lot of it. Doctors are being forced to, bring on bigger loads and, squeeze more patients into a smaller amount of time. And from my own experience that I've noticed recently, even with the implementation of EMRs and EHRs, that's actually taking away from time, which is the opposite of what it should be doing. So whereas we thought the technology of the electronic health record was going to improve the patient-doctor visit, what I'm finding is that it's actually cutting down on the communication, the direct communication that I'm having with my doctor. So, you know, but in other instances, it works very well and helps me out very much as a patient. But I'm losing that face-to-face interaction, and my doctor, instead of having this conversation with me, is now having this conversation with me, which is no good whatsoever, you know. And you know, there's ways around that. So I think that's indicative of a much bigger problem. And so, Hillary, I want to come to you and then ask if you think the current model of healthcare is working, and if not, you know, it's a big question. You know, what can be done about it, you know, from maybe a nursing perspective then? Oh, make sure to unmute yourself real quick.
Okay. What a question. I just spent an entire course of healthcare policy, you know, discussing how can we improve and, you know, deciding what's wrong in the beginning. So the Institute for Healthcare Improvement has that triple aim of better care, lower costs, and better outcomes. So that's something I think that we're striving for on many regards, and it takes the teamwork of physicians, nurses, ancillary staff, patients. Everybody is going to be chasing after these triple aim goals.
I'm forgetting to unmute myself here too to jump in. So before we go ahead and switch over into a bigger conversation here, we have one quick promo real quick, just some words from Medicine X that we'd like to have, and then we'll be right back with our list of panelists here in just a moment.
Let's take a quick break to remind those of you just joining us for this episode of Stanford Medicine X Live that we are here with a panel of students discussing the topic Medicine X, the Student Perspective. This program is made possible by the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. We have with us today a panel of students from medical schools, universities, and academic institutions across the country. E-patients and caregivers out there, what questions do you have for our panelists this evening? What advice would you give students looking to pursue a career in healthcare? How might patients help in the education of future healthcare providers? Healthcare providers, technologists, and researchers out there, how can we engage more students and young people in your work and research? Tweet us your questions or responses, and we'll do our best to have the panel address them during this episode of Stanford Medicine X Live for Tuesday, June 3rd, 2014.
Okay, so we are back, and I've got a great question here from another one of our e-patient scholars. We've got from Scott. He's at strangely_T1, so type 1 diabetic there. So Raul, I'm going to have you kind of answer this here. How does the increased chronic patient load on healthcare contribute to the problems that we're talking about here? And he says the insurance model based on acute incidents, healthcare professionals really like to be able to fix the problems, whereas chronic patients can't necessarily be fixed. So how does some of this sort of chronic patient play into some of the issues we're talking about here in healthcare?
Yeah, well, I mean, that problem is really well identified by Scott, because it really strikes at the core of the transformation. Atul Gawande has this wonderful piece in the New Yorker on cowboys and pit crews, and how we really need to transition from a medicine filled with a bunch of cowboys, soloist physicians who are experts in their craft, but narrowly focus on that, and moving towards a pit crew model. And I mean, and pit crews are much better suited to addressing this issue of chronic diseases than cowboys. Frankly, you know, dealing with chronic disease requires coordination across nurses and physicians, specialists, and primary care practitioners. You know, until we sort of manage to phase in that model, that team-based care, and that starts with medical education, we're not going to fully have a patient-centered experience for these chronic disease-facing patients.
Yeah, I couldn't agree with you more, unfortunately. So, Neil, I want to come to you. So this is kind of an interesting thing to pose to engineering. So, from your perspective, how does healthcare need to refocus on chronic patients? Because this is something I feel that's coming up a lot lately. Always does as a patient advocate for the chronic patient community, is that our healthcare system is just not equipped to deal with the chronic patients. Especially like in an emergent case, that's the easiest example here to use. People that are using an emergency room are usually, I broke my leg, this is the one time in my life that I'm going to need it, whereas you have a chronic patient who may be there for several times a year. And those staff just don't know how to handle it, and we don't have training across the board for chronic patients. So from kind of a design standpoint, what needs to change there for chronic patients?
Yeah, I think you bring up a really good point, that a lot of people think of hospitals as kind of this like once in a lifetime or a couple of times in a lifetime place where you go, you might be there for a couple of days, you get healed, and you never have to see it again. And I think that perspective is really apparent in the types of design and engineering choices that are made in hospitals, and they're not seen. The hospitals aren't places where a chronic patient who is there all the time can ever be restored in kind of a more like emotional sense. We get so focused on providing the engineering for fixing a problem and getting someone out there as soon as possible, that those people where who that's not an option for, they're kind of left forgotten and dealing with this system that's tiring and emotionally taxing. And I think one of the ways to start changing that is thinking of hospitals as these holistic places of healing, rather than just a place to deliver hard science, and a place where we can help chronic patients manage their pain or manage their diseases, incorporate their difficulties into like their life, and deal with these things over the long term.
Absolutely. Like I said earlier, you guys are giving me hope for the future. So Hillary, I know you wanted to jump in a little bit on this, so we'll come to you, and don't forget to unmute yourself there.
Okay. So I think the whole thing about what can chronic patients teach us, was that the prompt?
So, oh, Hillary, I think we lost you, so we'll come back to you in just a moment here. So I want to pull actually another question that we have from Twitter that came in from Dr. Mike Sevilla. He's at Dr. Mike Sevilla. He says, what is the student's vision for the ideal provider-patient care experience? If the current broken healthcare model is broken, could be thrown out. So Raul, I'm going to come to you real quick with that again. What would your ideal relationship there look like?
Yeah, it's a great question. I mean, I think in the abstract, the principles we're looking for are along the lines of what Hillary sort of outlined over Twitter, which is, nurses as co-captains with patients, but also physicians as co-captains with nurses and physicians, right? As truly equal partners in the process, as opposed to subordinates. And one of the ways of going about doing that is through technology. So having, for instance, at-home monitoring that allows patients to monitor their health in real time and relay any kind of changes or fluctuations to their caregivers at the hospital. These are ways to empower patients to become equal partners in the relationship.
I keep forgetting to unmute my own self. Sorry. So I was saying that I think the equal partners is a really important way to think of it moving forward. And I like what Hillary's saying here on Twitter, is that she tells her patients she's just the co-captain. That it's about patients, which is a really important thing. And that's a problem, because as it was brought up before, it's very much been this we versus them attitude, and that still exists, I would say, with pharma and patients and the rest of the community. So, Nicholas, I want to come to you and ask you about that. What are your feelings, and do you kind of perceive that being in school right now, that there is this we versus them issue within pharma, that's kind of similar to the doctor-patient we versus them that we've been dealing with and overcoming?
That is an excellent question, and something that I deal with every day. Actually, just the other day, I had an elderly patient come into the pharmacy and I was asking him if he knows why he should be taking his diuretic. It's just a standard antihypertensive for high blood pressure, and he was just like, well, I'm taking it, Nick, because you told me to take it this way. And I was just like, you know what? That is not the point. The point is that you are to understand why it is that you're taking it. You want to reduce your risk for cardiovascular diseases. And because he just kind of blindly just believed whatever I say, I was just like, okay, how about this? Every time you come into the pharmacy, we're going to make a deal. You take your meds on time, and you listen to what it is that I'm saying and why you're taking these, and you understand it, and then I don't bother you. So I try to make a deal with them. They have to understand it, and then I'll leave them alone.
Well, I think that's a good point as far as encouraging them to seek out education on their own, too, because I think that's a big part of where we got to where we are. And Howard, I'd like you to maybe jump in on this, and I'd like to know your thoughts on it, is that patients weren't encouraged to learn about their own diseases, to learn about the medications, that they were just learned or taught to be in a paternalistic relationship with their doctors. And so now we're switching to, when patients go online to find support and so forth, they're suddenly finding patients telling them, hey, do research, look at this, and it's kind of this whole new world that's opened up to them. What are your thoughts, Howard, then on, I guess, also how we got here as far as, not encouraging patients to learn for themselves and to be really passive participants in healthcare. So.
Yeah, I think that's one of my favorite memories from med school, is whenever you walk into a patient's room, and some patients will come in with a giant pile of papers this thick about things that they've Googled, and some people are like, oh my gosh, it's awful. Brit's pointing to herself. I thought that was the best thing ever, because it meant that the patient was engaged. They've already gone out there and looked to see what's available. They're already thinking about the issues. They're already trying to familiarize themselves with the terminology. So in terms of patients using Dr. Google, as someone on the tweet chat called it, I think it's a really cool, very recent phenomenon that only happened because the internet is there. And for me personally, and I haven't quite looked at the research on this, but for me personally, I find that it's actually a great equalizer, because it brings that much of that sort of knowledge distance between you as a provider and the patient. It sort of levels out that hierarchy. So it's sort of in the same way that people who are familiar with cars tend to have a much better time with the mechanic, because they can they can talk to talk and walk to walk about what's going on with their car. And when I see that happening with the patients, I find it's a lot easier to make that connection and say, hey, we can now sort of begin to speak the same language, exchange our ideas about what's going on, and then have that conversation together as to how your care might look going forward.
Absolutely, and I think that's the big thing, is making that decision moving forward, and that's something I'm battling with my own healthcare team right now, is how much of it is their decision for me and how much of it is my own decision. And even though I consider myself a very empowered patient, it's something I still struggle with every single time I walk into the doctor's office, because it's, the doctors that I'm dealing with are from a very different age, and I'm coming from now a new perspective, and trying to make those two mesh are really kind of interesting, and that ends up in some very interesting tales at points. So we got a really great question from @bcalpers on our tweet chat that I want to address here. So it says, is our healthcare model based too much on treatments and not outcomes? I'd say yes. And why should payers pay for ineffective treatments? So I don't know if anybody wants to jump in there. Feel free to unmute yourself or no. Raul, all right.
Yeah, sure. I'll jump in here. I mean, we're seeing that change, right? I mean, the Affordable Care Act has set up a variety of pilot projects to set up new models of care delivery and care reimbursement, right? So now all of a sudden you're having more and more hospitals and more providers being paid on the basis of quality and not just sort of volume-driven care, right? So I think there is consensus that the healthcare model as it is too much on this like fix-it treatment mentality. But there is progress being made, and I'm optimistic that this sort of coming generation of healthcare workers, in our generation coming healthcare workers, will emerge in a world where that's no longer the case.
Definitely. And Hillary, I'll kind of have you follow up on that as well. And so we'll come to you and hope that your mic's working this time, all right. So, you know, why should payers continue to pay for ineffective treatment and maybe not just ineffective, but say, you know, treatment that isn't tailored to them, you know, personality-wise is another issue, I would say, with patients, which is definitely part of nursing, is that, you know, if this doctor-patient relationship isn't right for me, you know, I should be allowed to go find another doctor who we kind of get each other and get the kind of treatment I want. So, you know, how do you see that changing forward, and how do you think nursing can help implement some of those changes? No, I think we can't hear you there, Hillary. So, Nicholas, do you want to jump in then?
Yeah, so a lot of patients are paying for, so pharmacy is all about focused on the treatment. We don't diagnose at all, and if we do diagnose, it's only if the treatment is a medication and not non-medication means. So so payers have to pay for ineffective treatments right now because the future of medicine, as Leroy Hood put it, he's a physician up in Washington, is going to involve P4 medicine: preventive, predictive, personalized, and participatory. And this P4 medicine model, it's going to take several years at least for it to take effect. So until then, the insurance companies are stuck until P4 medicine comes into play.
Definitely. So I think, you know, one question that, you know, I want to go back a little bit to Dr. Mike Sevilla's question, this, you know, what is each of your visions for the ideal provider-patient care experience? So let's move to more kind of like coming up with solutions here for some of these problems that, you know, you guys have so greatly outlined here. So Howard, what would you see as the ideal provider-patient care experience moving forward in a dream world?
In the dream world, if I had lots of money. I think that's a hard question to ask because I see healthcare in so many different contexts, right? You have your outpatient setting, which looks very, very different than your inpatient setting, and the relationships that happen there are very different. I think one thing that's really important for us to recognize is that it's no longer about the doctor-patient relationship. It's not about the nurse-patient relationship. It's about the doctor-nurse, pharmacist, tech, X-ray technician, all of the hospital staff relationships. So I think finding ways to incorporate the amount of complexity that we have in terms of the specialization of the roles into healthcare is one major place to start, both in an outpatient and an inpatient setting. So one of the things that I'm looking at with my dissertation research is looking at how we can start with interdisciplinary rounds that really empowered not just the patient to speak up about their own care during rounds, but also nurses and also techs and also social workers and pharmacists, and really sort of lifting everyone up on the hierarchy together. I do think that cultural changes can only go so far, and I think the sort of fundamental structure of how healthcare looks in the United States is flawed. And I think we've been talking a lot about that, about how reimbursements aren't tied into outcomes, or how reimbursements are really focused on treatment, and you get more money if you prescribe certain drugs or do certain procedures. And I think at the end of the day, we can push these sort of patient-centered care cultural changes as far as we can, but there really needs to be bigger structural changes in terms of how financial reimbursements and healthcare insurance actually works in this country if we were to see that relationship actually improve.
Yeah, definitely, and I like your idea of, you know, the grand rounds changing there, because it's a prime example. You know, the last time I was in the hospital, the nurses would be in my room the majority of the day. You know, that's who I saw most of the time, and I was interacting, and they understood where I was at. And, you know, just for instance, they knew at a certain date that I did not need to be released from the hospital at that point. They knew that I couldn't be okay at home and that I'd end up right back in the hospital. But the doctors had a very different opinion because they were only walking in at one time and the test results revealed nothing, you know, just because they hadn't found the answer yet was the thing. And so my nurses kind of acted as spies for me, which is such a backwards kind of model there. You know, they were having to tell me, look, we know you need to be here, put your foot down and say no when they come in. So they'd come in and the nurses just act totally different, going about their business. You know, it wasn't a team effort. And though it worked for me, ultimately, that's not how it should be. We should be able to openly discuss that, say why, you know, why do I need to still be here? You know, what am I feeling? What are they seeing that you're not seeing? Also, you know, validating the nurse's knowledge of the patients on a day-to-day basis. So that whole group aspect there. So Neil, I want to come to you about that same thing. You know, in an ideal world, you know, what does the healthcare experience look like, or could that look like?
Yeah, I love the idea of fostering stronger relationships between patients and providers and caregivers. I think right now patient loads are too demanding in most settings for doctors and even nurses to really have that relationship with the patients that I think is necessary for a positive experience. I think part of what could lead to that change is like a changing criteria for med schools and looking for students who really have that passion to connect with patients and to like really help them out rather than just apply some like scientific knowledge or a medical procedure. But really see them as people and as partners in kind of this puzzle of solving health. And I think we're getting there with med schools kind of redefining what they see as the ideal medical applicant. But I think we can go a lot farther and do a lot better.
And I keep forgetting to unmute myself. So, Nicholas, I was trying to ask, in a pharmaceutical setting, what would the ideal patient, you know, a pharmacy technician or pharmacist relationship look like moving forward?
The type of relationship that pharmacists and pharmacy technicians, you're asking, have? Yeah.
In an ideal world, what would that look like for you?
In my idea, well, I just gave a presentation to the to an exec board for the Target Pharmacy, and I was pretty much telling them that pharmacy technicians should be given more quote-unquote clinical responsibilities. They should be educated on how a lot of these connected health devices work. Some of these medication adherence devices that are attached to both the Google Map and the phone, reminding patients where and when they're supposed to be taking their medications, and pretty much at the point of sale, telling them, oh, there's this in case they feel the patient needs it. Pretty much educating technicians more on these connected health devices. Just because pharmacists are already ridiculously busy, I'm not entirely certain if they have the capacity to take on more education and provide that to the patient in a community setting anyway. Inpatient is a completely different story.
I think there's a way to improve communication without, you know, being at a detriment to either relationship, either to the doctor or the patients, obviously. You know, and a lot of it goes back to what Howard was saying about, you know, the patient load that doctors have and so forth, and kind of who is necessitating that. You know, I've seen personally several, you know, small doctors and, say, physical therapists go out of business recently because they insisted on a more patient care-based model, and yet the insurance companies weren't backing that, and they weren't making enough money to literally keep their doors open, which is just very sad because this is where I was getting the very best care, but that model was not sustainable currently in our own healthcare system. So my 2 cents there. I want to give a couple shout-outs here. We've got @MarcyMom joining us all the way from Singapore in the discussion, so really appreciate that. And also we have @Engage Health IQ, Dr. Mike Sevilla on here, and Scott Strange as well. and Helen, who is at HellTweet as well. So really appreciate you guys joining us there on the live feed. If you have any last-minute questions, please tweet them to the hashtag MedX, and we'll try to get those answered. So I want to wrap up here, and Raul, I'm going to come to you first about this. You know, since you're all currently still in school and working in school, from the education you're being given, and you know, I'm led to believe that plenty of you ascribe to the fact that, you know, education does not stop, you know, at the end of the books and at the end of the day. You know, education keeps going, as I can tell. So where is school currently lacking as far as patient-centered care? What are you not hearing that you want to hear, and what needs to change in school so that we can actually help implement these, you know, sort of worldwide as well? What needs to change in engineering, design schools, medical schools, everything? So.
Yeah, so I guess I can most directly offer my experiences, you know, in engineering training, which is what I'm studying now. You know, I think that there are two key elements that could go a long way to improving the educational process for us. One is on the team-based side. So engineering training is phenomenal for teaching us how to work in multidisciplinary teams with other engineers in the same field and with different specializations, but also, you know, with scientists, with physicists, and so on. But I think where we still have tremendous room to grow is in the formation and operation of teams that cut across disciplines, that cut across experiences. So for instance, in my undergraduate and graduate training, we have a variety of design projects. We're working to create new drugs, new devices to help medical care. But the teams are staffed with scientists and with engineers. And I've never been staffed on a team with patients, for instance, or with nurses. Whereas these latter two sort of groups could offer a variety of perspectives that could really enrich the design process and enhance the end product, which is often developed in the isolation of patient contact. So I think that would be really, really important, really relevant. The second would be just more sort of patient clinical contact. I think it's very easy as an engineer to focus on the math, focus on the constraints, focus on the optimization, but ignore the fact that human interaction is key to determining and defining the success of a device or a technology. And the earlier engineers are forced to internalize that, the better.
Absolutely. And, you know, like I said, you know, I've been fortunate enough to get to join in on a few classes and kind of, you know, lend my own perspective, you know, as a long-term patient. And it's been really fascinating to me, you know, the robust questions I get and the amount, you know, they're just, students are just waiting for it. And I think we need to set up more of these situations where they get the chance to ask the questions, because sometimes also from an engineering perspective or any perspective, you don't know the questions to ask. And the patient is what, you know, we live with those questions every single day. So by collaborating early on, we can help build a better education and really help take the knowledge that we've gained as, you know, chronic patients or just patients in general, and really help kind of put that back into learning. So Hillary, I want to come to you with the very same question. So how can schooling adapt to some of these needs, and what needs to change moving forward?
Moving forward, I think patients give us lectures or, you know, in the classroom setting, telling us about their experience. We learn tons about their diseases, their conditions, their limitations, but be a really important component in really bringing the human back to medicine.
Absolutely. So we'll try. Medicine X is working on that, so we'll see what we can do there. Howard, I'm going to come to you next. So very same question to you. What needs to change in schooling moving forward?
Yeah, I think one really cool concept from anthropology and sociology is the idea of the hidden curriculum. So when you attend your, you know, medical school, nursing school, pharmacy school, you'll go to classes to learn clinical medicine and to learn about drugs and to learn about pathophysiology. But at the same time, there's sort of a second message that's being sent out that's maybe not as explicit. And a lot of the work that's been done looking at medical education is really asking the question of what sort of hidden messages are we teaching our students? And I think there's sort of two big ones that are really getting in the way. One is that there's a hierarchy and that we need to respect it. So as a medical student, I was taught that physicians were at the top of the food chain. I had no idea what a nurse did until I started doing my research. Like, I just had literally no idea like what happened after you wrote that order. It just sort of magically happened. I didn't realize how much complexity that there was. So I think medical school does goes a really long way in teaching in teaching that separation between disciplines. And I think the sort of second big message that's taught is that even though we're here primarily for the patients, it's okay for us to be pushed by the system to our absolute limits. And I think, I don't know about pharmacy as much, but definitely within doctors and nurses are much better about this than doctors are. We're taught that we need to work, like we look up to the 100-hour-a-week surgeon who runs out from the OR suite or from like one suite to another, and we're taught that working really, really hard and pushing ourselves and being tired all the time is the way to go. And I don't think that we necessarily recognize that style of lifestyle isn't facilitating our ability to actually connect with patients, because how can we be empathic when we're working so hard? So I think both like teaching us the hierarchy and then teaching us that it's okay for us to be sleep deprived all the time are two really big hidden messages in medical curriculums that get in the way of delivering patient-centered care.
It's really interesting. I haven't thought about that necessarily. Just sort of reinforcing some of the old in there. And need to break that down. So Neil, I'm going to come to you with the same question. What in schooling do you think needs to change? What are you not being taught yet that you'd like to see in there?
Yeah, I think I'd echo what Raul said in that we need to remember the human aspect of all of this. I think especially in engineering, we can get caught up in like just designing the product or just designing the space, but ultimately these things are meant to be used by humans, and so we're doing a really big disservice to ourselves and to others by not thinking about that. And I think that can happen through increased communication between departments in a school, so between the College of Arts and Sciences and the School of Engineering, people in the humanities and people in the hard sciences, to kind of get these discussions going about how we can collaborate and kind of meld these disciplines together. And I think bringing in more patient-centered and human-centered design and thinking into our everyday lives, and getting the end user's experience, the end user's expertise and perspective.
Yeah, and then just from my own schooling experience, what you said, that's very interesting, because departments typically just did not talk to each other, and it was only if we really needed something from somebody else, and it was seen as you were doing something very experimental, and that's not the way it should be, because I know some schools, or specifically in different parts of the world, medicine, for instance, has been not under the science department, but it's been under arts and humanities, which when you look at the style of what's being taught there, that lends itself to two very different schools of thought in and of itself, where it's being kind of housed, and the thinking that's being, that it's being surrounded by. So Nicholas, we're going to come to you with the same question. What would you hope to see in schooling? What needs to change moving forward?
Well, at UCSD School of Pharmacy, we're doing, I think, an okay job. We've, just these past 2 years, we provide 2 hours of digital health lectures in their pharmacy informatics class for the first-year student pharmacists. We're pretty much showing them how we're supposed to tweet with patients, how we're supposed to respond to patients' medical complaints on social media, how we're supposed to counsel them on some of the medication adherence devices out there and some of the pharmacy-related devices out there. And the number of digital health hours going into this class is increasing by 4 as of this year. So they're getting 6 hours in a 10-week class. I want to echo, and I totally agree with the engineers and the designers on this panel, that there needs to be a much more heavy push for cross-disciplinary interaction between the pharmacy students and some designers, because a lot of us are science majors, and we have very little utilization of the right side of our brain, for lack of a better way of phrasing it.
Well, and I think that's just a good note to end on right there. A prime example that we have to remember to use, the left and right sides of our brain, just as healthcare needs to learn to use all parts and pieces within it to solve the problems moving forward. So really appreciate everyone joining us. It looks like we're all out of time, so thanks everyone for joining us tonight. Please stay tuned for some of the important announcements from Medicine X in just a moment. And I want to thank everyone on the tweet stream for joining us and for tweeting in your questions. And if you have any more questions for our panelists, I did go ahead and tweet out their handles on there, so please keep the discussion going and use the hashtag MedX, and we will see you all very soon. Thank you so much.
Thanks so much for joining us tonight for this episode of Stanford Medicine X Live. We'll see you back here on June 10th, 2014 at 5:30 p.m. Pacific Standard Time for another edition of Stanford Medicine X Live. As a reminder, this program is made possible by support from the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. If you haven't yet done so, please take a moment to follow our YouTube page at www.youtube.com/Stanford Medicine X so you can continue the conversation online and stay informed of program updates. From all of us here at Stanford Medicine X, we want to thank you for joining us tonight and remind you to join us again this Thursday, June 5th at 6 p.m. Pacific Standard Time for another edition of Stanford Medicine X Live, featuring the final episode of Design for Health, a class from the Stanford University School of Medicine. This week, we'll feature e-patient Emily Bradley and recap trends in healthcare design with Dennis Boyle from IDEO and Nick Dawson, President-elect of the Society for Participatory Medicine. For all of you out there taking time to tune in with us tonight, thank you for joining us and being part of the conversation. Don't forget that registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology and medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. You'll want to take advantage of these programs while our regular registration pricing is still available until August 1st, 2014. A special thanks to our guest panelists this evening. From all of us at Stanford Medicine X, we'll see you next time.